Hello, this is John Kanellopoulos from Athens, Greece, and New York City, New York. Very excited to share with you this case. We're with the LenSx femtosecond laser here in this very high myope, about 20 diopters of myopia and a myopic cataract. This young lady in her 50s. We're focusing the laser. As you can see, the applanation is not optimal to the limbus. I'm nevertheless able, through the small pupil, to center my capsulorrhexis, which is the purple line, and my lens fragmentation, which are the two yellow crossed yellow lines. I will try and reduce the size of my capsulorrhexis from 5 millimeters to 4.5, and now I'm using the OCT to define the rhexis height, upper and lower. You can see the fuzzy white material that the OCT shows in the lens, and this is part of the cortical cataract changes present in this young lady. This case is under peribulbar anesthesia, and now this is the technique I've described many years ago. I'm going to bring up the lens fragmentation to almost the anterior capsule level. Remember, my fragmentation is more narrow than my capsulorrhexis, so I will not be cutting the capsulorrhexis with my lens fragmentation, and the laser will perform here the silver. It's not actually capsulorrhexis, it's a capsulotomy, since it's performed with the femtosecond laser. And this is the first step of a all laser cataract procedure, a pre-chopping, as we can see here, with the femtosecond laser, and a capsulotomy performed that will continue with a nanosecond laser, the Cetus, made by ARC Laser in Germany, with which we will visco-dissect the 4 cataract segments that we see created here. Femtosecond laser is over. I'm testing here the Cetus nanosecond laser probe. You can see that spark of light coming out of the opening is a 0.9 millimeter bore on the nanosecond laser edge. My 2.75 incision, main incision, and I'll use the same keratome to perform a 1 millimeter, as you can see here, paracentesis. I'm using epinephrine here to increase the capsule. You can see a little bit of a bubble peeking under the anterior capsulotomy. Good sign, part of the lens fragmentation gas is coming out. I'm using viscoat here to inflate the anterior chamber and get a little bit more of dilatation of the pupil, and methylcellulose on the cornea in order to better visualize the eye and not have to spray BSS and create a epithelial hardship. I will enter with the capsulorrhexis forceps just to assure that I have a perfect capsulorrhexis, and I do actually. You can see the free cap of the capsulorrhexis had been moved aside from the viscoelastic, and I'm removing it here because of the small pupil and the cortical imperfections. It was hard to visualize, and here I'm using viscoat to visco-dissect the 4 segments of the cataract, and also help to burp any gas that's present behind the cataract and close the posterior capsule more superiorly. So I have visco chopped the lens. You can see 4 completely separate segments. I will allow some viscoelastic to come out of the eye, and then with my irrigation cannula I will perform hydrodissection. And having separated the lens, there's a little stress here of having gas push the posterior capsule and potential rupture. You can see how the inferior quadrant of the lens just popped into the anterior chamber, and now the procedure becomes extremely easy, as I have pre-chopped the lens with femtosecond laser and my viscoelastic. With the hydrodissection, I have moved one of the segments of the cataract into the anterior chamber, and now with my Cetus, the nanosecond laser probe, you can see the sleeve irrigation around it is very excimer-like. I'm using the AMO signature device in a vitrectomy mode to pulse my laser and also provide irrigation aspiration. It's quite an interesting concept, and you can see the small pulses of the laser are emulsifying the lens material. This is of course not a hard lens. It's probably a +1 out of 4 or a +2 out of 6 scale, 1 to 6 lens and hardness. It's quite opaque, and I particularly find these lenses quite challenging to remove with phacoemulsification, as I do not have enough cataract hardness to be able to divide and conquer or chop intra-operatively. The beauty with the Cetus probe is that the bore I mentioned before is 0.9 millimeter. The laser opening gives me a good grasp. Of course, we're running this real time. I'm using here my irrigation cannula to again pop the cataract material into the anterior chamber and ensuring that I have good hydrodissection. And I will help here separate the pre-chopped pieces of the cataract and create some space for me in order to be able to come in with my nanosecond laser probe and remove the cataract material with safety. So with this small delay behind us, re-entering here and grasping the what's left of the initial quadrant that I removed with the laser. You can see the laser pulses here, and now I have created a platform on the next quadrant to be able to grab it, and you can see the purchase ability of the nanosecond laser. I'm able to grasp the quadrant, tilt the cataract. I'm of course being extremely careful here. This is a very high myope. I do not want to have any problems with the capsular bag. I will try and rotate the lens. This assures me that I have good hydro delineation and hydro dissection. I will complete the separation of this second quadrant and purchase it with my Cetus probe. Bring it up. This will tilt the whole cataract vertically, and now the procedure has become quite easy. You can see that despite the epinephrine used intracamerally, the pupil is still small, and it was small even before the femtosecond laser pre-chopping of the lens and capsulotomy. So this was not a femto-induced meiosis. Unfortunately, this patient has a pupil that does not enlarge in agreement with making the procedure more easy. And meanwhile, we've gone through the second quadrant, now the third, with our nanosecond laser. The pulses are set to 4 Hertz, so 4 pulses per second at a minimal energy level. The total energy I used in this procedure was 1.6 joules. And just a reminder for those of you not familiar with this technology, although there's a sleeve on the laser probe, there's no heat produced in this probe, as there is a fiber optic going through the probe, reaching the opening of the probe and shooting on a titanium target that is present within the probe to create plasma and thus emulsify the cataract material. So we're going slowly but very securely. And you can see the good control provided by the irrigation aspiration with the AMO signature device. I mentioned before that I'm using the vitrectomy mode just as a means to pulse my laser. There's a tube attached to the phaco device that receives the gas pulses, and these are eliciting the laser pulses. Of course, on my pedal, we're finished here with the cataract removal. We'll start irrigation aspiration. With my pedal, as I'm stepping down, the first position is irrigation, as in any routine phacoemulsification. Second position is irrigation and aspiration. And third position, all the way down, the signature device is starting to pulse as if it was performing a vitrectomy, but these air pulses are igniting my Cetus device that is attached to the AMO device, creating a very nice coordination of this procedure performed in a very similar fashion with a routine phaco procedure. The advantages that we saw in the procedure while we're watching in real time the removal of the cortical material. Of course, special care is taken here due to the limited visualization from the small pupil. In this patient, I will use my Sinskey hook to move the pupil to the side. Very careful not to grasp anterior capsule with the pupillar margin. So I was saying that the main advantages is that there's no heat production, no potential damage to the peripheral cornea at the adjacent to the incision from heat production. Second, the bore of the nanosecond laser probe is quite large and has a good purchasability of the cataract material, and thus I do not have to embed my phaco tip within the cataract material that is so soft in this case and in danger compromising the capsule. I will use a split aspirator now on my left hand through the paracentesis, and use the same irrigation aspiration probe on my right hand, now used only for irrigation, in order to complete the irrigation aspiration of the peripheral and outermost cortex in this case. Of course, the numbers here, I mentioned this young lady was a very high myope. The biometry showed us an optimal lens of -8, and I want to underline that. You're familiar, most lenses used in cataract procedure have a plus denominator, so this was a -8 lens. We decided to use a -5 lens in order to create a fudge factor for this patient and not induce hyperopia. So this is only available in a MA lens on the Acrosoft series material and not a single piece lens. So I will, after you're seeing here, inflating the capsule bag with methylcellulose, I will enlarge the initial incision of 2.75 millimeters. By the way, I've tilted the microscope here. My incision is at the 12 o'clock position. You can kind of tell from the superior conjunctival vessel. So I will enlarge the 275 incision to almost at 3.2, and I chose the incision site to be with the rule with the patient's astigmatism. She had also 2 diopters of astigmatism. So I'm using my main incision here as a astigmatic keratotomy incision as well. This is the MA lens. We saw it's a -5 power lens. Little care here in folding these lenses. They may, instead of fold, crumble because they're very thin. So I use a forceps in the middle of the lens. Quite nice folding here, and I will enter with the first haptic in the capsular bag, seen here, and once I'm certain that the lens is placed in the anterior chamber and the haptic in the capsular bag, release my lens forceps, and then using a bimanual technique, a Sinskey on my left hand, to secure and stabilize the optic of the lens, and a toothless forceps on my right hand. I will dial in the lens in the capsular bag. Always like to orient my lens haptics horizontally. That reduces the possibility in a very large myopic capsule sac, the displacement of the lens. And then we'll perform irrigation aspiration in a routine fashion, hydrate the incisions, and use myoclone to attain meiosis. So irrigation aspiration here, ensuring that the lens position is fine. We can admire the perfect job done by the femtosecond laser and a perfectly centered capsulorrhexis. To note that in this particular age group, younger cataract patients, it is quite challenging to perform a perfect capsulorrhexis manually, since the capsule material is quite rubbery. It's very easy to run smaller or larger. Here the acetylcholine, myoclone in the anterior chamber, meiosis locking down the lens, ensuring that the wound is watertight. I hope you found this presentation interesting. Thank you so much for watching. This is John Kanellopoulos signing out.